Hello.
I request everybody to please mute yourself. From my end, I have muted everybody. So far, we have not started. Once we start the webinar, we are waiting for participants to join. Shalu ma'am, we are about to reach the maximum limit. Can we start?
Yeah,
we have
can start.
97 participants right now.
Yes, we can start.
I request everybody to please mute yourself. Requesting everybody to please mute yourself. We have 99 participants so far. Reach the maximum limit of 100.
Yeah, we can start now.
Good evening, one and all. I once again welcome you all to the IAOMR online lecture series in collaboration with IDA Southwest Delhi branch. The topic of today's lecture is Disclusion Time Reduction in Treatment of TMJ Disorders. The speaker is Dr. Varun Kunte. He is a craniofacial pain and TMJ specialist, founder and director of Arthrose Headaches, Facial Pain and TMJ Clinic. May I now request Dr. Shalu Rai, Professor and Head, Department of Oral Medicine and Radiology, IDST, and Honorable General Secretary, IAOMR, to please introduce the speaker.
Good evening, everyone. Thank you for your participation. We have a successful webinar being conducted by Indian Academy of Oral Medicine and Radiology. This is the 8th webinar that we are having. Today's speaker is Dr. Varun Kunte, who has completed his MDS in the field of oral medicine and maxillofacial radiology. He is a founder and director of Arthrose, which is a chain of headache, migraine, facial pain, TMJ, bite and posture correction clinic in Mumbai. He is consultant specialist in orofacial pain and TMD in various hospitals in Maharashtra. He is the second doctor from Asia to receive prestigious DTR certification from Dr. Ben himself, and he is at present only DTR certified doctor in Mumbai. He has undergone intense training in DTR by Dr. Scott Green, Dr. Robert Kurstin, who is an inventor of DTR. He also practices neuromuscular dentistry and is member of ICCMO, which is the largest organization in the world for neuromuscular dentistry. He has several advanced biometric instruments for treatment of craniofacial pain, TMJ disorders, sleep apnea, etc., such as Tscan, bio-EMG, joint vibration analysis, etc. He is established speaker in the field of TMD, orofacial pain, headaches, and has conducted several lectures, courses, hands-on workshop in the same. He is a panel speaker at various conferences and also a key opinion leader in the field of TMJ disorder. I welcome you, Varun. The outline for today's lecture, that is DTR in treatment of TMJ disorder, would be, he will be dealing on the concept of biometrics in TMD, myofascial pain, Tscan for occlusion, EMG for muscle, DTR in treatment of TMD, what to do, when not to do DTR, treatment options other than DTR, neuromuscular dentistry, and much more. I welcome again Dr. Varun and hand over the screen to Dr. Varun Kunte.
Dr. Varun?
Yes.
Yes, sir.
Honorable President, Dr. Ravi Kiran sir, Honorable General Secretary, Dr. Shalu Rai Madam, my mentor and guide who's here with us, Dr. Ajay Busreddy sir, members of Indian Academy of Oral Medicine and Radiology, dear friends, good evening, one and all. I am delighted to speak to you this fine evening. It is a matter of pride and privilege to speak to you all this evening. As you all know, we are going through one of the toughest times in human history. In these toughest times, I wish you best of health. Today's topic is disclusion time reduction. However, I am going to tell you a story. And this story is about a young and a dynamic dentist from 1980s. The hero of our story is Dr. Robert Kurstin. Now, Dr. Robert is a prosthodontist, and back in 1980s, Dr. Robert was a postgraduate student. In his department, he saw an equipment. He was searching topic for his thesis. An equipment was called as Tscan. Like today, even back then, the dentists were using articulating paper to find out more about occlusion, occlusal interferences, premature contacts. Tscan was an equipment with which you could do all these things in a computerized way. So Tscan mapped the forces against the time. So you could actually come to know which tooth came in contact first, which is a premature contact, which stayed in contact longer than usual, which is an interference, and is the force distribution equal? So Robert Kurstin found it very interesting. He started using Tscan during his PG time. During the residency, Dr. Kurstin started getting a lot of cases of facial pain, headaches, MPDS, myfacial pain. And a curious mind, such as Dr. Kurstin, he observed one thing. He observed most of them on Tscan showed that they lacked canine guidance. Most of them showed that they had a lot of posterior interferences, a lot of posterior friction during chewing movements. Dr. Kurstin then thought, why not? Why not use Tscan to correct their occlusion, to restore their canine guidance, to get rid of the posterior interferences, to make the chewing more efficient? So just to revise a bit, canine guidance is basically this particular movement where the patient goes to a side and the posterior teeth disclude immediately. So the amount of time it takes for a person to start an excursion and to achieve canine guidance is called as disclusion time. Robert noted that in most of the cases of myofascial pain, this disclusion time was prolonged. There was group function occlusion and a lot of posterior friction. So what Robert thought that there must be a reason why these all patients are exhibiting such a similar etiology. So Robert dig deeper and he studied all these things and he came to a conclusion. He found out that there are certain special sensors in this posterior teeth and we call them mechanoceptors. They are in the PDL and they are they are connected directly to the CNS, right? So the amount of time it takes for achieving the canine guidance, if it is more, then this disclusion, that's posteriors going out of contact, this time is also increased. So these mechanoceptors would be active for longer than usual. This means these mechanoceptors are responsible for muscle activity. Your masseters, temporalis, and all other muscles, the activity of these muscles were controlled by mechanoceptors. The more amount of time these were active, your muscles were hyperactive. So if the muscles are hyperactive for a longer time, eventually what's going to happen? They're going to get fatigued. Like if I ask you to run for 2 minutes, probably nothing would happen. But if I asked you to run for 2 hours, even you would get tired, right? So similarly, if there's an excess load on masticatory muscles, eventually they will get fatigued. Of course, this would be different for different people as the physiologic tolerance is different for different people. But eventually, due to anaerobic respiration and lactic acid buildup, these muscles will get tired and eventually ache. That is what we call as myofascial pain. So Robert found out that the root cause could be prolonged disclusion time and occlusal interferences. And he introduced a concept called as Disclusion Time Reduction, often known as DTR. So what DTR does is, it restores canine guidance. It takes out posterior interferences. It shortens the disclusion time so that it limits the activity of mechanoceptors, so that muscle load reduces, so that muscles start breathing oxygen again, anaerobic respiration stop, lactic acid buildup stops, and muscles work better. Patient becomes pain-free. So all the myogenous component that is coming from the occlusion is practically eliminated. So for doing this, Robert used a very advanced technology. One equipment I've already told you, that's Tscan. So what Tscan does is it digitally checks the occlusion. And what EMG, on the other hand, does is it checks the muscle function. So one side you have something called as Tscan, and the other side of the screen you can see there are some muscles. So the red are temporalis and the green are masseters. If you see, the TAR is right temporalis, TAL left temporalis, MMR is right masseter, and MML is left masseter. And on the right hand side of the screen, you can see the Tscan. A smaller blue circles tells me the disclusion time. So in this particular case, the canine guidance is not there. There's a group function. As you can see, the contact on 24, 25, 26. And the disclusion time is pretty much enhanced. It is 2.15 seconds, which is very high. Normally, for a patient, the disclusion time has to be less than 0.4 seconds. It has to be less than that. So this particular patient, as you can see in the EMG, during the excursion, the muscle activity is tremendous, right? So this is my own case. And on the same day, we did DTR for this patient. We practically took out the occlusal contact from 24, 25 to 6. We shortened the disclusion time, and immediately what we saw is now the smaller blue circle tells me that the disclusion time is back to normal. It is 0.23 seconds. The bigger blue circles immediately tells me that the muscle activity has significantly gone down, and the symptoms of this patient are now better. Her headaches are less. She was diagnosed as trigeminal neuralgia, and now she was taking, before this, she was taking 7 to 8 tegratols a day. Now she's just taking 1 tegretol per day, and the pain levels are much in control. This is the same day result that I'm talking about. Another thing Robert checked is the function of the TMJs. So he used a technology called as joint vibration analysis. And what JVA did is it told him amount of active damage in the TMJ. So smaller blue circle here tells me that the left and right TMJ have values around 80 and 35. The normal value for total integral is less than 20. So the values are like 3-4 times more. The bigger blue circles tells me that there's a high amplitude vibration, which indicates that the disc is getting displaced. There's a disc displacement in this case. Now, after we did the DTR, the muscles got relaxed, the joint got slightly repositioned downward and forward. And in the next image, if you can see, the smaller blue circle tells me that the values are now within normal limits. They are back to less than 20. And if you see the bigger blue circle, you can see the waveform has significantly reduced. So by doing DTR, he could control the active damage in the TMJ. Of course, not in all cases, but majority of the cases. So his concept, he could prove it objectively. Since then, it has been more than 30 years. And Dr. Robert and few of my colleagues, we all have published a lot of data regarding DTR, regarding Tscan, EMG, JVA. It's available. And we have, Dr. Robert has published three volumes of a book, so which is a great evidence of literature. He has treated thousands of patients, and together I think we have treated many more. So for the sake of this presentation, I'm going to tell you about DTR in 3 parts. So in the first part, we'll see how DTR is actually done. In the second part, we'll see when to do the DTR. And the third part, which is I think more important, is when not to do DTR, right? So let's quickly get into it. That's how DTR is done. Okay, so basically DTR, disclusion time reduction, is done by a procedure called as ICAGD, immediate complete anterior guidance development. Immediate complete anterior guidance development. Basically what it means is that it is a bite adjustment or an occlusal adjustment procedure where we do certain amount of occlusal corrections or addition or reduction basically. So where do you reduce or where do you add or where do you calibrate? So there are 3 points. There are 3 points at which you do some corrections. Number 1, non-working cusps. So you correct any occlusal mark that is there on the non-working cusps. You correct the cuspal inclines. Okay. Number 2 is that you correct cuspal inclines. Number 3 is you, on the working cusps, you don't touch working cusps except for cuspal inclines, and make sure that you have point contact as described in Dawson's textbook, that an occlusion should have a point contact, not too many slide marks. So basically what DTR does is it maintains the occlusal contact without reducing any height. We're not reducing any cuspal height. The adjustments are minute, extremely precise, very, very minute in microns. We are taking care of non-working contacts. We're taking care of cuspal inclines, the slide marks, and we are making a point contact occlusion. That's what we do. So this is only done when you have an anterior guidance. When you have a canine contact, only then the contact is taken from all posterior teeth. Okay. Otherwise, there is no point in just blindly grinding posterior teeth. We have to make sure that the canines are in contact, the 1, 3 and 4, 3, 2, 2, 3 and 3, 3. They are in good surface contact. Only then a person would have a canine guidance. Otherwise, he's always going to have a certain amount of excessive posterior friction. So what are the goals of DTR? Basically to maintain a uniform force distribution. So right side and left side, it's almost 50-50 to maintain a uniform force distribution. To eliminate the premature occlusal contact. So basically your mandible occludes with your maxilla. Mandible and maxilla, when they come in together, sometimes there are some occlusal prematurities. So your mandible kind of has to adjust to these prematurities to get around it and finally come in maximum intercuspation. This puts up extra load on your muscles. So we would eliminate these prematurities and make sure that the mandible and maxilla contact very smoothly, right? Then we eliminate some occlusal interferences, okay, especially in excursion, any high force points. In excursion, whatever is staying in contact beyond the recommended disclusion time, that is 0.4 seconds. Beyond that, whatever stays, we have to take care of that. We have to make sure that it doesn't stay and the muscles get off immediately. So the result of everything is to shorten the disclusion time. That means basically person achieves canine guidance much faster, right? And eliminates the posterior friction. So basically you reduce the posterior friction so that the muscle activity is reduced. So muscles are able to function more efficiently and the myofascial pain stops. So the root cause of the muscle pain is treated. If you just treat the muscle pain with physiotherapy or medications or acupuncture or yoga, this would just be a temporary thing, and the root cause, unless it is addressed, these things, the muscle pain would always come back after a few months. So DTR tries to address the root cause of the problem. So typically, after the adjustment, this is how the occlusion looks. The blue arrows here are giving you the slide marks. So this causes the posterior friction. And after we have adjusted, after we have adjusted the occlusion, the left-hand side of the screen, which has less occlusal marks, you can see that we have maintained point occlusion. Okay, the occlusion is perfect. The muscles are responding favorably to occlusion. So we have made sure that the patient is not suffering from any occlusomuscular hyperactivity, right? So in a nutshell, let's take an example of this case. So the smaller blue circle on Tscan tells me that this is a high disclusion time. Normal value is less than 0.41, but this value is 0.63. Patient complains of headache, facial pain, tinnitus. And if you notice the bigger blue circle here, on the EMG, you are seeing that the muscles are hyperactive. Now, muscles are supposed to be active during the clench, okay, when the patient is biting in the center. So if you can see my cursor in the center between B to C, the muscles are active. And during C to D, the disclusion time, the muscles are supposed to rest, like the resting EMGs here. However, her muscles are hyperactive, and because of that, she's having some pain. If you can see on the Tscan on 2-3, which is the left canine, I don't see any occlusal contact. So unless I maintain the occlusal contact on 2-3, I cannot adjust the posterior teeth. So what we did is we gave her a dab of composite on the palatal aspect of 2-3, and we developed an anterior guidance for her. We developed a canine guidance for her, and then we started adjustment in the posterior teeth. The result was the disclusion time is now back to 0.26. The occlusion is very nice. If you can see, the muscle activity in the center is amazing. The muscles are now more with symmetry and synergy, and muscle firing is good. But if you see the circle, the large blue circle, the muscle activity here is minimum. The previous image, if you could see, the muscle activity in that section was very high, but now the muscle activity is reduced. Disclusion time is back in control, and this patient, to our surprise, even the tinnitus went down. She's been to like 6, 7, 8 ENTs, but nobody could tell her why her tinnitus was there. The tinnitus was because of an occlusomuscular problem, the hyperactive muscles. And when we treated that, the tinnitus pretty much reduced. The headaches were gone. The facial pain pretty much reduced. Amazing, right? And how difficult it is for a dentist or for a doctor to do an occlusal calibration, especially when you see it on the screen. It's very simple. So all of us can do that. It's very, very, very simple. Let me give you an example of another case. This lady here, as you are seeing, that a smaller blue circle is telling me the disclusion time is 2.43 seconds, which is extremely high. Okay, it is 7-8 times more than usual. The another blue circle on Tscan is showing the groove function occlusion, which is causing the extra muscle activity on EMGs. Okay, so note the muscle activity on EMG, the groove function contact in Tscan, and in the next image, if you can see, the canine guidance is restored, which has practically eliminated the muscle activity in EMG, and the disclusion time is now 0.17 second, which is drastically less. I mean, which is like 20 times less. And this is on the same day. So immediately within 3-4 days, this patient comes back and says, my headaches are gone, facial pain is much better, facial pain is gone almost. The clicking which she had, it reduced, it got muffled. So the patient is happy. So it's basically an objective science which rules out the subjective bias between the doctors. You see it on the computer screen, you make some calibrations, you recheck whether you have done the right or not, and accordingly the computer, the software, the equipments will guide you. So it's very, 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 very simple. So that's how you do a DTR. You build a canine guidance, you make sure that the posterior interferences are taken out, you make sure that there is minimal good muscle activity, and then you do this for a few times, and then the patient gets better. So for the second part, when to do DTR? You understood this, that canine guidance is important. You have maintained the canine guidance, you have taken out the interferences, you have done the best job as far as possible. But when do we do that? Do we do it for all TMJ disorder cases? Absolutely not. Absolutely not, right? So the question is that when you do DTR, it's a very strict protocol for doing DTR. It's not a loose cannon that any TMJ disorder case or any myofascial pain comes to your doorstep and you just take your Tscan and EMG and start scanning and then do a DTR. That's very callous. So there are some symptom checklists that you make sure you analyze the problem in detail. You take a detailed history, you do a detailed clinical examination, you do radiological examination, you do postural evaluation, you check the any osteochondral growth defects, any osteoarthritic changes in CBCT. If possible, if it is feasible, please do an MRI. On MRI, you will see a lot of things. Especially if there is an avascular necrosis, which is fairly common nowadays. Since when we have started taking MRIs, we are noticing things that we had not seen before. So MRI is very useful for TMJ disorder cases. A lot of patients have airway issues, sleep apnea. Airway and TMJ go hand in hand. Often one is dependent on the other. There's a detailed intraoral examination to check if there is any obvious malocclusion, if there is canine coupling. That means basically if there's a broad surface-to-surface contact between 1-3 and 4-3 and 2-3 and 3-3, upper and lower canines. If there is good amount of posterior intercuspation. So that is also very important, that the good amount of posterior intercuspation gives you a baseline good muscle activity during clench, which is essential, right? So DTR will essentially take care of the excursive friction. And if you have a good posterior intercuspation patient, it is always better for DTR. Of course, the arch size and shape, very important. A lot of time, patient has allergies, and as a child, they have tonsils and adenoids, which enhances mouth breathing, which causes maxillary constriction, and the mandible is also smaller. The tongue size is large. The tongue comes down, and the arches, get constricted, which causes abnormal swallow, and then everything goes haywire. The mandible goes backwards, and in such a case, if you just do DTR, then it's not going to help, right? So DTR is a very, very strict, it has a very strict protocol. It can be done in selected cases. It cannot be done in all cases. So we'll see what are these cases. Now, again, another important is the psychometric evaluation. A lot of patients do suffer from depression, stress. So that also has to be taken care. But in my personal opinion and my colleagues' work so far, after doing DTR, the depression scores are better. In fact, Dr. Prafulla, Dr. Nick, and John Radke, Ben Sutter, everybody, and Dr. Kurstin, everybody, they have published a study in which they have proved that post DTR, the Beck's depression inventory was much better. After all this is done and you have made sure, only then you take out your biometric gadgets, that is Tscan, EMG, and JVA, maybe jaw tracker, and then you assess and you make sure that the muscle pain is coming because of the occlusal interferences and occlusal friction. Okay, and only then you treat a patient with DTR directly. Otherwise, you don't do a DTR in every case. All right. Of course, these are vast majority of cases. In my practice, personally, what I have seen is more than 50% of cases can be done with DTR, with of course certain limitation, but more than 50% is a great number for treating TMJ disorders. So for understanding when to do DTR, it's very important to understand TMJ and TMJ disorders. Contrary to a popular belief, TMJ problems are not just pertaining to the temporomandibular joint. They're basically an array of conditions. There are close to 40 conditions under TMD, temporomandibular disorders. Now, if you are just looking at the TMJ and then you are trying to correct the TMJ, and then we are magically hoping that things would get better, it will not. Or if you are just correcting the teeth and muscle components and hoping that the TMJ disorders would get better, it will not. So there are a number of conditions. There are some TMDs which are arthrogenic, which have a major arthrogenic component in which you cannot do DTR. There are mainly some conditions. There is an occlusomuscular problem in which you can do a DTR. There is an arch, the jaw size discrepancy, in which case you may require an orthodontic treatment, a neuromuscular approach towards treating. There is a physiologic tolerance, so the general well-being of the patient also has to be increased. So there are so many factors while considering a treatment plan for the patient, and it's not a random thing that we do, right? So temporomandibular disorders are have varied etiology. So what DTR does is it treats myogenous TMD. That means any muscular dysfunction during TMD, that DTR will take care. Of course, when the arthrogenic component, that means when the TMJs are stable and adapted, and only the occlusomuscular component has gone haywire, which is majority of cases. A mild clicking here and there is fine, but majority of cases have occlusomuscular component. So when you do that, then the DTR is helpful. Not in all cases. So for that, you should have some basic occlusion which is there, like good contact on all teeth. The canine coupling should be there. In severe dento-maxillofacial anomalies, it cannot be done. So you have to correct those anomalies first and end the case with DTR. Right? So DTR is mainly for myofascial disorders, not all TMD. So presently, there is a chaos in the TMD world. And there are so many doctors, there are dentists, ENTs, neurologists, there are chiropractors, physiotherapists, and everybody wants to grab hold of a TMD. And everybody is trying their best to treat TMJ disorders, but with their own specs, with their own aspects. What we actually require is an interdisciplinary approach. So TMJ disorders do require an entire array of specialists, which will take care of all things. Not just a dentist treating occlusion, not just an ENT taking care of ear, or not just a psychiatrist treating for stress. You require a team, right? So as a dentist, we can do a lot. A majority of the TMD is dental in origin, and we can definitely treat it, right? So there's another important factor, and which is often neglected. Often there's a tendency among patients and doctors to talk in absolute terms. Will this help me completely? Will this get rid of pain completely? Will this therapy be 100%? Are you 100% sure about it? So a lot of it depends on the physiologic tolerance. Somebody may have a great muscle tonicity. Somebody may have a great tolerance and his symptoms may be cured very easily, because you are going to use your jaw for chewing. It is definitely going to cause a certain amount of muscle activity, right? And if your muscles are so weak that they are not going to take that muscle activity, and so it's going to be painful for you, right? But if you increase your muscle tonicity, if you increase your muscle strength, then yes, a limited posterior friction would be bearable for you, and you can get along with that for the rest of your life. So a lot of times when the patients are like this, they're very thin, there's loss of muscle tone and everything, there's a poor general well-being. No matter, even if you do a DTR, even if you observe a good reduction in their muscle activity in EMG, still they are not able to cope up with that existing muscle activity. Also, there is a certain amount of chronic permanent damage that comes with chronic muscle activity, muscle hyperactivity. Your muscles do have a certain limitations, right? I mean, if you are 40 years of age and your muscle activity is there since 20 years, so there is a certain amount of chronic irreversible damage that you may have to live with. So there is a limitation in that sense when we are treating. So that physiologic tolerance is different for different people, and we have to take that in consideration. And that is why some patients have symptoms, while others, although they have signs, they don't have symptoms. They do get symptoms later in life. So it's a general saying that men grind their teeth and women have headaches. Actually, women are smarter. They get symptoms, and that's why they get treated and live happily. And men grind their teeth and still don't realize that they've got a problem, right? So it's actually the hormonal imbalance. I mean, the estrogen plays a big role in alleviating the symptoms of TMD in women. That's why women tend to have more TMD. So I want to tell you that we are not just tooth doctors, okay? We have a capacity to do much more. Do you know, with eliminating this occlusal friction and treating TMJ disorder as a whole, not just DTR, but as a whole, you can get rid of chronic headaches, you can get rid of migraines, you can get rid of many cases of neuralgia. In fact, my mentor in TMD, Dr. Ben Sutter, has undertaken a trigeminal neuralgia study, and so far he has treated 25 cases of neuralgia with success, which is a great thing because we have practically no hope for neuralgia. There are patients with cervical dystonia that are getting treated. There are patients with cluster headache that are getting treated. There are patients with neck problems, spondylitis, the lordosis, the postural issues, they are getting treated. I mean, look at this rat study. I mean, the occlusion has a significant role in the posture. So what they did is they added a 0.5 millimeter composite filling on the right first molar of the rat. And after 1 month, the middle image here, B, look at the change in the spine. And they added another filling on the contralateral side, the left side, and took an X-ray after 1 month, and look in the image C, the spine has come back to normal. So who deals with the occlusion? You do, right? So you have a power to influence your patient's life much beyond giving them a great smile or giving them implants. You can restore their functional normalcy. You can get rid of their pain. An amazing thing to do. And a lot of times, your medical counterparts may not be able to do that. And your cases, you can tell them that you may not be able to get rid of migraine, but I may be, just maybe in select number of cases, I can. So I would like to tell you that you can definitely do more than just fixing teeth. That's what you're meant to do. And I think oral medicine specialists look much beyond teeth. So we are in a good position to learn this science and get ahead of other specialties. Very important thing I want to tell you that when not to do DTR. Okay, DTR is not a Ramban Upai. It's not a one solution that fits all. There are a lot of cases where you can't do DTR and you shouldn't do DTR. A dentoskeletal abnormalities, the deformities, anterior open bite. When there is an open bite, you don't have anterior guidance. So, I mean, no matter how much you reduce in posterior, you will never get an anterior guidance. So, not in that case. severe degenerative changes of the TMJ. If the TMJ is not stable and adapted, the chances that post DTR you may have enhanced resorption. You never know. So there's a problem there. So you cannot do that in severe degenerative changes of TMJ. TMD, which is mainly arthrogenous. For an example, if you have a dislocated shoulder, would you be able to lift weights with that shoulder? Absolutely not, right? So similarly, if the discs are displaced, there's a certain amount of muscle inhibition that is there with the masticatory muscles. So you may not be able to get rid of everything, all symptoms, if the main symptom is from the arthrogenic point of view. So that is where there's some limitation. The severe dental malocclusion, like there's no canine coupling, there's a lot of dental wear. So where there's already a treated teeth, I mean, occlusally worn out dentition, how can you do a DTR in that case, right? You cannot do. Very important thing. There are a lot of patients, rather most of us have group function. Does that mean it's abnormal? Absolutely not, my friends. It's not. If your group function is causing a significant amount of muscle activity, only then it has to be treated. Otherwise, no. I have seen countless number of cases where you have group function, but this doesn't cause any significant muscle activity on EMG. So you don't do DTR in these cases. There are many doctors have seen that they claim to do a DTR without EMGs. I would say, please don't do DTR without EMGs. It's you compare Tscan on one side, on the same side you check EMG, and if occlusal interferences on Tscan are causing muscle activity on the EMG, only then you adjust the occlusion. Although I understand this occlusal calibration is extremely fine, it's microns, like 50 microns, 70 microns, it's very less. It's very precise. I mean, it's a very precise science, but still, it's an irreversible thing that we're doing. So we have to be very, very careful before taking up a case for DTR. So I would not advise doing DTR just with Tscan alone. And there are many other factors like JVA, jaw tracker. There's so many things which you need to take care. If the etiology of ND is lying elsewhere and you are treating with DTR, you're not going to get the results, right? So we have to make sure that this case is for disclusion time reduction, and only then you treat this case. Again, the DTR is not a magic bullet. So it reduces the intensity, frequency, and duration of the symptoms. It is done usually in 3 to 5 settings over a period of 2 months or 3 months. Pain may recur, move. Your mandible may take a little time to adjust to the new occlusion that you're giving. There are so many other factors. There's forward neck posture, there's arch size discrepancy, there's sleep apnea, there is psychiatric issues. There's so many issues, and these also need fixing before or simultaneously during DTR. DTR doesn't take care of everything. Yes, a lot of times airway function, it is known to improve after doing DTR, but it's not 100%. It may not be just enough for the patient. So if the sleep apnea is severe, you please ask your patient to get treated for sleep apnea. There are so many other factors which are also involved, as in the DTR is not going to correct the constricted arches or malocclusion, right? It's just going to eliminate the occlusal friction. So if your tongue is not fitting in your narrow maxilla and you're having a swallowing problem, which is causing the digastric hyperactivity and pain, doing DTR may not help to an extent. Of course, the jaw may get positioned slightly downward and forward, which will release the posterior tongue space, but still it may not be enough for all patients to get rid of symptoms, right? So any occlusomuscular problem, DTR, you can definitely do it. And after correction of all these problems by orthodontic treatment, prosthodontic treatment, stress management and everything, the final occlusion that is done, on that final occlusion, you do a DTR, right? Now, the final part is that when we are doing a DTR, and we're not getting the desired results. For example, we can't do DTR in many cases. So what do you do? So there are some alternative treatments. There are many alternative treatments, but from our point of view, I think the most significant one is neuromuscular dentistry, or maybe a broader term is there are many doctors who use splints for treating TMJ disorders. So yes, they can be used. Neuromuscular dentistry is a more precise science because it is all measured. The occlusal forces are measured with Tscan. The joint damage is measured with JVA. The muscle activity is measured with EMG. The mandibular movements are tracked with jaw tracker. And ultra low frequency tense is given to relax the musculature, so that at this particular neuromuscularly stable position or a physiologic rest position of mandible, a splint is made. The splint is called as a neuromuscular orthotic. It is anatomic. It is of the shape of the teeth, and a good occlusion or functional dentition that a patient is supposed to have. That functional dentition is given on the orthotic. The patient is made stable on the orthotic. How do you do that? Basically, you do a same DTR that you're going to do on the occlusion, on a good occlusion, that you same DTR you can do on a neuromuscular orthotic. So your occlusion is stable, your muscles are better, your TMJ is better. After you're wearing the orthotic for 6 to 8 months or 10 months, you go in for phase 2. So basically, this is how the orthotic looks, usually on a mandibular arch. It is either acrylic, either resin, or a CAD-CAM mill. There are many varieties. So phase 2 is basically you look for a permanent solution. So what do you do? If the arch size is constricted and that's causing a swallow EMG abnormalities, you try and increase the arch size, expand the arches. If there is an obvious malocclusion, you try to correct with the orthodontic treatment. If the occlusal table is worn out, you try to restore the vertical height with occlusal rehabilitation. If there is any surgical procedure that is warranted, which is like extremely rare, you can get that done. All these things have to be done under digitally managed biometric evaluation. Biometric means Tscan, EMG, JVA. So whatever you're doing, you have to digitally check it so that you know that whatever treatment you're offering to the patient, it is helping in the favor. I mean, it is working in the favor of the patient. The objective science or the objective signs are, let's say, they're telling you that the occlusion is stable, muscles are stable, the TMJ is better. Now, whether it is the patient's physiologic limit, whether the patient's physiologic ability is able to overpower your therapy and get the patient's symptom back in control, it will depend on each patient. Also, there's certain amount of chronic permanent damage. There's certain amount of sympathetic outputs coming from neck and back, which are more with the age. So you may not be able to get rid of them in spite of doing a neuromuscular dentistry or DTR treatment. After the final occlusion is given, let's say you've done an ortho, you've done some fillings or some crowns, whatever is required. And after that, you digitally check with Tscan EMG, you do the calibration, that is, you do the DTR, make sure that the muscle function is back to normal. So there are a lot of things in TMJ disorders, and DTR takes care of a small section of TMJ disorders, which is mainly a myogenous component in TMJ disorders. So if a TMJ disorder patient requires, let's say, a number of treatments, DTR could be the one of the treatment, or let's say the final treatment that you do for your patients, right? Now, this is a patient testimonial that I want to show you.
I'm taking treatment at Arthur from last 2 months. I was introduced to Arthur by my dentist, Dr. Amruta Agankar. I would just like to point out a few of my symptoms, which any of you might be suffering from. The first thing is that you suffer from headache. One more thing is that you will suffer from jaw pain. There was a shoulder and neck pain. I was also suffering from hand pain. The same side where I was suffering from jaw pain. It was very high during this time. I was not able to.
Excuse me. Just a minute. So I'm going to just stop the share and restart it again. Just a minute. Just a minute.
My name is Niyati and I'm taking treatment at Arthur from last 2 months. I was introduced to Arthur by my dentist, Dr. Amruta Agankar. I would just like to point out a few of my symptoms, which any of you might be suffering from. The first thing is that you suffer from headache. One more thing is that you will suffer from jaw pain. There was a shoulder and neck pain. I was also suffering from hand pain on the same side where I was suffering from jaw pain. At times, there used to be a back pain as well. The sensitivity was very high during this time. I was not able to identify what are the issues related to it, why I'm suffering from all of this. I was continuously visiting my dentist. When I visited arthros, analyzing my problems digitally, I got to know that all of these problems are associated with one another. And after doing DTR treatment, if I have to rate my problems from scale of 1 to 10, reduced by 50% itself in one sitting. I was taking follow-up with Dr. Varun for 2 months, and in 2 months we did 6 to 7 sittings, including follow-up. And in those 6 to 7 sittings, I can say that and my pain has reduced by 80%. The remaining 20% is still there, but I do have 1 or 2 months remaining for my treatment. And I'm sure that my pain will reduce by 100%. I would like to thank Arthros, Dr. Varun Kunte, and my dentist, Dr. Amruta, for giving me the right direction and giving me the best treatment available in India for jaw and muscle-related pain. Thank you.
So basically, this lady was suffering from headaches since many years, and sensitivity, in fact, she said it's from childhood. So after doing DTR, the sensitivity went down. It's basically a frictional dental hypersensitivity. It's not cervical dental hypersensitivity. So after reducing the posterior friction, the sensitivity went down. The headaches and facial pain was reduced by 80%, and which was significant for her as it was affecting her work life and her personal life. So it's simple. I mean, few sittings, just 3 to 4 sittings of minor occlusal calibrations, and patients usually report back with much relief. So, which is a very, very good thing. With all that in mind, I have started something called as Arthros, and you can reach me at Arthros TMJ on our all social media handles. My contact information is displayed here. This is during my training with the inventor of DTR, Dr. Robert Kurstin himself, and few of my colleagues, my seniors, Dr. Vikas and Dr. Prafulla sir, during the training in Indore. So in conclusion, I would like to say that there are biometric equipments in TMD, which are Tscan, EMG, joint vibration analysis, jaw trackers, and these are very efficient and these are very effective in giving you the real-time data. And it will rule out the subjective bias and it will bring more objectivity to the treatment plan of TMD. Once you do the objective analysis, in addition to clinical radiological evaluation, we'll be able to precisely treat our patients and we'll be able to precisely predict the prognosis of the case, which is very important, right? We have to predict how much of a relief this one would have. The second thing I would like to say that DTR is an efficient treatment modality when done in a correct case. It's not a one solution fit everything. It has to be done very, very precisely, and you got to get certified before you do a DTR. It's very, very much precise science, although it may sound that few occlusal corrections here and there, and the patient is, coming back and saying it's very nice, I'm feeling better. But, it's a very big journey to learn this much and do this. Personally, it has taken me years of efforts to learn this, and I'm sure Robert has been perfecting his own techniques for past 30 years. So it's a very precise science. DTR is a very effective way of treating TMJ disorders for myogenous component. And the last thing I would like to say is that we are not just tooth doctors. We were not meant to treat just teeth, and all the subjects, anatomy, physiology, pharmacology, general medicine, surgery, they were not there just for the general knowledge. We can influence many things. We can influence cluster headaches. We can influence migraines, posture disorders. We can influence so many things. And we have a power beyond our recognition. We can do much more. We can do much more than our medical counterparts, and which is a great thing to do. So I think oral physicians, specialists in oral medicine, radiology are perfectly suited for treating TMJ disorders. We are trained during our residency to look beyond the teeth. In fact, most of the times we look beyond the teeth, and we are in a perfect situation to treat TMJ disorder. TMJ disorders being an integral part of my field, our field. So I think together, if we pull in all the efforts, if we adopt this science, I think we can achieve much more. And our branch, oral medicine, oral radiology, will achieve much more acclaim, more heights than what we are doing today. So we have a great scope of doing things, and I think already many oral medicine doctors, Dr. Atul Sattur sir, Dr. Renju Jose sir, Dr. Patu Joy, and so many, Dr. Nafde, everybody. I mean, we all are there and we all are doing our best. And any of you or everybody, whosoever wants to learn this, we all are there and we'll do our best to treat you. We would personally like to see all oral medicine radiology doctors coming together and creating or expanding the boundaries of this science. Thank you so much. I thank the IAOMR for giving me this opportunity, and I thank you all for patiently listening to me for past 1 hour. And lastly, I would like to thank my guide, Dr. Ajay Busreddy sir. It's very important that he tried to push us to do the best. He tried to tell us to do to venture out in unknown territories, to develop a lateral thinking. Always said that don't get into general things. There are so many people who are doing great. If you want to do great with your MDS, it's that you do add value to the books. You just don't read from the books and imbibe, but you add something to the book. So this is my sincere effort of adding to the book, and with that in mind, I have started Arthros, and it is an exclusively headaches, facial pain, and TMJ clinic. So far, this journey is amazing, and I look forward to working with all of you. Thank you so much.
Thank you, Dr. Varun, for an informative session.
Thank you, Dr. Varun. If you have any queries, you can just post in here, or you can unmute yourself and ask them one by one from Dr. Varun. Any queries, anybody?
I think everybody has understood everything. They don't have any questions.
Varun, it was such a brilliant session, ma'am. Yeah. So everybody has to understand. And those in such a simplified manner, he explained such difficult things. TMD is supposed to be really difficult, but he explained it in a very well way.
DTR, I think we have 3 big volumes on digital occlusion and DTR, but to sum it up in 45 minutes, it's a difficult task, but I've done my best. I hope that all of you have understood the science, and if not, I am there. You can always contact me if you're interested, and I'll be there to help you all.
I hope my screen is visible.
Yes.
Yeah. So thank you, Dr. Varun, for such an enlightening lecture. On behalf of IAOMR, I would like to present the certificate of appreciation to Dr. Varun Kunte. I would like to thank Dr. Ravi Kiran, President IAOMR, Dr. Shalu Rai, Honorable General Secretary IAOMR and President IDA Southwest Delhi Branch, Dr. Puneet Batra, Secretary IDA Southwest Delhi Branch, for your unconditional support in making this event successful. This is the link wherein you can click for your certificates of participation for this webinar. Thank you all the participants. Thank you one and all.
There are some questions, Dipankar, that you can take up.
Oh, I can't see.
I think they must be in chat box.
Yeah, it is. One question is, how do you interpret, what is the interpretation of EMG? Okay. How do you interpret the EMG?
Okay. Well, it's a very big modality. So the interpretation is going to be very complex, but let me just sum it up for you. Ideally, when the patient is clenching, we are supposed to have a particular EMG reading. Let's say it's between 100 to 300 microvolts. All right. So you make sure that the baseline EMG readings are there. And when the patient is doing an excursion, like left lateral or right lateral excursion, during that time, the EMG readings are supposed to be minimal. Patient is supposed to perform this excursion with minimal EMG readings. Right, the less number of muscle fibers engaged in an excursive movement, more efficient, more easy it is for a patient to do this movement, and more resistant the patient will be to develop myogenic pain. Apart from checking EMGs with Tscan, EMG itself is a very big modality in determining the treatment plan. So we have to check the resting EMGs. We have to check the sitting standing position EMGs. We have to check swallow EMGs, clench EMGs, everything. So if there is a, let's say, constricted jaws and patient's tongue position is abnormal, patient has abnormal swallow, I can see that on the EMG that the muscles are not functioning well, and only then I would correct that arch discrepancy. Otherwise, I wouldn't, right? So EMGs will guide me in determining my treatment plan, and it'll be a constant checkup whether whatever I have done have the muscles responded favorably to my treatment or not, right?
Okay.
There's a question raised by Dr. Tanmay. Your opinion on patients suffering clicking jaw deviation following mandibular third molar extraction. What is your opinion on patients suffering clicking jaw deviation following mandibular third molar extraction?
Okay. A lot of times after a traumatic extraction or already the ligaments are loose, suppose there's a TMJ ligament laxity and the disc is anyways loose. After you take out the third molar, the occlusion balance perhaps shifts. Okay. If it shifts favorably, nothing happens. If it doesn't shift favorably or the extraction is traumatic, mouth opening is for longer duration, already stretched out disc and ligaments, the disc gets pulled forward in front of the condyle. And now when you try to open the mouth, the disc tries to slip back and forth, and that causes the clicking sound. Okay, the moment the clicking sound starts, the occlusion changes. These changes may be very minor. It will be detected on Tscan. Now, by doing DTR, in many of the cases, the jaw gets repositioned and the mandible gets repositioned downward and forward, which can kind of recapture the disc, but not always. Okay, a lot of times clicking sound persists even after that. And it takes a while for the TMJ to adapt. So either the minor bone resorptions or the disc desiccation that happens, and then the disc goes back in position. So once the disc is displaced, it is displaced. You may try to recapture the disc using a neuromuscular approach by getting the jaw downward and forward, but the displaced disc is a displaced disc. So there is a certain amount of limitation when the clicking of TMJ starts, and if you don't treat it at all, don't reduce the active damage in TMJ after checking JV and everything, the chances are that the disc won't go back and forth. It will be locked in one place, and then it will be very difficult to treat because the reduction in mouth opening, it has a certain amount of inhibition of the muscle. So no matter you reduce the occlusal friction or you do whatever you want, there is going to be a certain limitation as far as the joints are concerned. So the clicking, I'm afraid, is irreversible. Right?
One more question is there, Dr. Varun. It says, is there any step-by-step procedure for the 3 to 5 sittings in DTR?
Okay. Normally, how it, okay. Normally, there are, let's talk about first 3 sittings. That's what we do. Let's say, yeah, let's say we start today for a patient. We do the all scanning and everything, and we come to know that he's a DTR patient, and we start the treatment today. So I'll see him after 7 days for the second sitting. I'll see him after a month for the third sitting. And if required, I'll see him after another month. That is at the end of second month for fourth sitting, and at the end of third month for the fifth sitting. Now, typically the amount of reduction is very, very minimal after first or second sitting. The maximal adjustments is in the first sitting. Let's say 90% of adjustment is in the first sitting, and then 7 to 8% is in the second sitting, and third sitting onwards is like just minor calibration, or even you can choose not to do and wait. So this is a step by step. You check every time with Tscan EMG. You check every time with joint vibration analysis. And if you find any abnormality in Tscan and Tscan causing that in EMG, only then you go ahead and adjust it. So that is how we go step by step, because after every adjustment, your mandible tries to get adjusted to new occlusion. It kind of repositions when the muscles are relaxed. So this new position may bring up some interferences. Hence, DTR is usually done in sittings, not, otherwise we could be doing it like in first sitting, we could do everything. But then the mandible repositions. So to counter that new contacts, you have to keep the patient under follow for at least like 2 months.
Finally, one more question, Dr. Varun. A treatment plan for the complete denture patients. Treatment plan for complete denture patients.
Okay. Now, the mechanoceptors are in natural teeth. Okay, they are in the PDA. Complete denture don't have PDA, right? So in that case, you can't do DTR there. Basically, in complete denture, we have something called as balanced occlusion. So where we on purpose maintain some contact on the non-working cusp, right? So on a glass, if you remember your teeth setting time, on the glass pad, we used to check whether the buccal cusps of maxilla are in contact or not. So there we can maximum what we can do is we can take a Tscan and we can check whether if there is any premature contact or if there is any high force point on the denture, and we can calibrate it there. Yes, when you're making a denture, if you do it using neuromuscular way, if you reposition the jaw, downward and forward, you relax the TMJ, it is likely to help. Okay, but if you are talking from today's point of view, DTR, not for complete denture patients, only for patients with natural teeth.
Okay, so Dr. Varun, there is one final question by Dr. Ajay Bhush Reddy, sir. He says, how much is the investment to start DTR practice?
Well, I am not a company person, so I'm not at the discretion to reveal any price. But I can tell you how much I bought it for. So it's roughly, I mean, the Tscan, EMG, JVA, everything costs roughly around 25-30 lakhs. It was around that for 4 years back. I think if we can go. There are a number of models that have come which are much cheaper. So you can start your practice with just Tscan, EMG, and quadratens, and do the JVA thing later. Of course, having JVA always helps, but the financial limitation are different for different people. So I would say for DTR, main is Tscan and EMG, and JVA comes next. So if you can afford, get everything. But if you can't, go in for a simple version of a Tscan, going for a smaller EMG. So I think start slowly and then you upgrade. That's what I have done. I started slowly. I bought a simple model of Tscan, bought a small EMG, and then I upgraded. So that much you can do.
All right. I hope all the queries have now been sorted out by Dr. Varun, especially after answering Ajay sir's question. So with that, I am just once again sharing my screen for the feedback form and the link for the certification. I hope it is visible.
Get a slideshow done.
I hope my screen is visible.
No, it's not. Yes, it's visible now, but you can just zoom that.
So this is the link for downloading the feedback form and the certificate of webinar. Kindly click on this link to attain your certificates and the feedback form. Thank you all the participants for your patient hearing. Thank you, Dr. Varun. Thank you, Shalu ma'am. Thank you, Dr. Puneet Batra. Thank you, one and all.
Thank you. Thank you, everyone. Thank you, participants. Thank you, Dr. Varun, once again.
Thank you, ma'am.